trying to avoid those triggers. All of those triggers that were listed aren't going to affect every person, but they may be able to identify what are their triggers. They're going to live with it pretty much lifelong. Most of the sickle cell disease shows up in the childhood because typically, it is genetic. So they're going to have experiences well before adulthood. So by the time you're encountering them, probably in an adult situation, they're probably going to know much more about the disease for themselves. But if it's a new onset, certainly talking about those triggers and teaching them. And typically, they're not going to be able to manage their pain or their hypoxemia at home. They're going to have to seek medical attention if it becomes severe enough. I'm just distracted because I'm looking at the waiting room here, so it's admitting some people back into the class. Any other questions? Okay, so I want to start us off with some questioning about sickle cell disease. So I'm going to go ahead and share this with you. Okay, so you should be able to see, I can see Amanda and Angelica, so you should be able to see a question. Okay. So I'll give you a chance to read this question. Basically, what you're looking for is you're looking for abnormalities that you are going to identify in this assessment that needs follow-up.
Your high white blood cell count, temperature, your blood pressure's kind of low. So I think your hemoglobin.
Okay, so I'm assuming everybody's had a chance to read it. So I'm going to open my chat. So basically, which of these findings stand out to you as something that needs to be followed up, maybe reported to a physician?
Lightheadedness.
You can put your answers in a chat. Okay, so I see a lot about blood pressure, white blood cell count, temperature, feeling lightheaded, hemoglobin and hematocrit. Let's see if I didn't miss anything. Dizziness. Okay, good. We know both parents are sickle cell disease carriers. So this patient is very high risk of having the disease herself, right? She doesn't have any cyanosis of her lips, nail beds, or palms. So it's a good thing because that could indicate hypoxemia. Lightheaded. Why is she lightheaded?
could be low oxygenation.
Right? Any other reason? Lydia wrote low circulation. Typically, lightheadedness is probably going to be kind of an orthostatic experience, something where the blood pressure has changed, that activity is not being compensated well enough by the body, and therefore you experience symptomology associated with the low blood pressure. Less likely are people who are hypoxemic going to feel lightheaded unless they are going through a hyperventilation stage where they're blowing off so much CO2 that that's going to cause them to feel lightheaded, but hypoxemia of itself won't do that. When I read this question, I actually had a problem with the hemoglobin and hematocrit because, and this is the encounter that you're going to experience and the frustration, I should say, that you're going to experience whenever you go to a different hospital, whenever you consult multiple resources, is everybody's going to throw these numbers off a little bit, where something in one textbook might be normal, but another textbook might indicate it as abnormal. Okay, and you're going to face that when you go to different hospitals. We don't all use the same normal references in values as, say, another hospital does. I can't necessarily explain it. Could be the machinery that they're working with, but you're going to find these normal values slightly off. So when I consulted the Pagana and Pagana just to make sure about the hemoglobin, it actually says that a normal hematocrit, a normal hematocrit for an 18-year-old, which this patient is 32 to 44%. So that makes this hematocrit normal. And that was my frustration when I saw this question, because I didn't pick that as an answer, but it certainly is included as an answer. And then the hemoglobin for a normal 18-year-old is 10 to 15.5. So that's falling within normal as well. Typically, I don't see a lot of excitement around a hemoglobin unless it's less than 10, especially with symptoms. It's not something that we would transfuse in this case at 11.4. And then hematocrit, typically we're not too concerned unless you're getting to about 25% or less. And then with symptomology, you'll find clinicians more open to transfusing blood. These values wouldn't warrant that, just so you know. All right, so certainly the white blood cell count is elevated. There's no question there. I can tell you a normal serum bilirubin level is 1.2 or lower. So that is elevated. And that could reflect those sickled cells clogging up the liver. Right? And then, of course, we do have a temperature validating the white blood cell count elevation. The pulse rate's fine. We're not concerned about the heart rate, 89 per minute. It's less than 100. We're not going to get too excited about that. Respiratory rate's fine. It doesn't seem like she's complaining of shortness of breath, but she's not necessarily compensating for that at a respiratory rate of 20. And then the blood pressure, looking just at that value, I would not be concerned about 98 over 48. However, she says she's feeling dizzy or lightheaded with those values. So then that indicates maybe that blood pressure is not sufficient enough for her. I can tell you personally, I run in the 90s on average, and I'm asymptomatic with that. So again, when you're dealing with numbers or values, make sure you have other evidence to support why you're concerned about those values. Okay. All right. All right, I'll give you a chance to read this next question.
I think oxygen therapy is initiated. antibiotics. Prepare to give. Damn. I think contraindicated for that one. I think indicated. So indicated. Maybe contraindicated.
Okay, so I'm going to go ahead and open this up to a chat. We'll just take it one by one. Indicated, contraindicated, which means it could be harmful, or non-essential, which doesn't really make a difference or is not necessary at this given time. Initiating oxygen therapy.
That's indicated. Yeah.
Good. We know that this could be a source of possibly any complaints of pain. We know that she was experiencing some shortness of breath from the earlier scenario, and this is a carryover. So initiating oxygen therapy is indicated. At what level? Like if you were going to put her on oxygen, what would you put her on? Good. Kind of shot in the dark. 2 liters is pretty common. I like Angelica, depending on the SpO2. Good. So yeah, 2 liters nasal cannula is probably pretty common. We don't have any indication to throw her on a simple mask or a non-rebreather at this point. She's not in acute respiratory distress. But yes, let's figure out what her SpO2 is, and maybe we can titrate it to that. And certainly oxygen is a drug, so you do want to use as little as you need to get the result that you desire. Okay, so what about preparing to give packed cells?
Cells. Just low red. I think she had a low red blood cell count. No, 120. I forgot what it said.
Good. So we kind of have a conflict between non-essential and contraindicated. Contraindicated means it could be harmful. At this point in time, it's not going to be harmful necessarily. The blood will be screened. We know, at least according to whatever values they were using for hematocrit and hemoglobin, the normal values, they consider her results as being low, but they're not to a point that it's absolutely essential. So I would put this in the non-essential category because it's not going to be harmful, but it's not necessary at this point in time. Okay. How about antibiotic therapy?
She does have a fever, yeah. High white blood cell count, yeah.
Good. She's got an elevated temperature. She has a white blood cell count to corroborate that temperature. Some kind of infectious process is going on, so indicated for antibiotic therapy would be correct. How about or the 4th choice, refer the patient to a social worker to discuss end-of-life care.
Yeah, that could be harmful.
Okay, so we have another conflict between non-essential and contraindicated. I'd put this as contraindicated only because if we start talking to her about death at 18 years old, we are possibly doing psychological harm. Okay? So it is certainly unnecessary to a point that it could be harmful to the patient. So in this case, it would be contraindicated. There's no reason to talk about end-of-life care. How about withholding pain medication until a drug screening is done?
That's definitely contraindicated.
Good. I like the fact that you chose contraindicated. That would be the correct answer. absolutely unnecessary to do a drug screening, harmful because she's in pain. We don't want to prolong that unnecessarily. And again, no reason to do a drug screening.
Indicated.
And then the last one, keep the head of the bed elevated at least 30 degrees.
Short of breath.
Excellent. Indicate it. Let's go down to the next one. Oh, this is one of the ones I didn't want to do. Hold on a second. You can do it. I'll give you the answers.
Acute vaso-occlusive episodes, sickle cell complications such as
Okay, so I won't ask people to put this in the chat because it is, a lot of words to enter. So I will complete the sentences for you. You can compare your notes. So basically, as a result of the client's diagnosis of sickle cell disease, the nurse is aware that she could have multiple complications, including acute severe pain periods known as acute vaso-occlusive episodes. The nurse also monitors for other major SCD complications, such as stroke, acute kidney injury, and sepsis. So if you chose those as your answers, you're good to go.
teaching about hydroxyurea.
You can look hydroxyurea up if you'd like. Go ahead and Google it.
Anti-neoplastic. Increased number of, yeah. I think it's A. I don't think it's B. I don't think it's C. I think D would be pretty good.
Okay, we'll just take them one by one. You can say yes or no. How about letter A?
Yes. No.
Okay, good. So you would want to include that because this medication can suppress the bone marrow. So it would be real important because remember the bone marrow is responsible for all of our blood cells and we don't want to suppress them too low. How about B?
I think so. Yeah? Oh shit. Didn't know that.
Good. So the majority of you are choosing yes, and so yes, A and B would be correct. How about C? So yes, you don't want to include that in the teaching. D. Good. So she's going to be immunosuppressed on this medication, avoiding people with infection, public places with large crowds. I would even also add wearing masks as well, that help. How about E? Good. That is true. F. Excellent. No. And then last one, G. Good. There's no cure. All right. Another select all that apply. Take a stab. Okay. So we're thinking about those triggers, those episodic triggers. A.
Really?
Technically unnecessary.
Yeah.
He's 18, so not legal to drink in most situations. But anyway, not necessary at this point. So let's exclude A. How about B?
I think so. I think so.
Good. So I would include B. How about C?
Hey, C, I think is true.
How about D?
I think D would be good. True.
Perfect. E?
Yes.
F?
Yes.
G and H?
Yeah?
So really, all of them should be included except A. Okay, good job, you guys.
Professor, I had
Yes.
a quick question about one of those. With the vegetables, is there any contraindication for high vitamin K vegetables like dark leafy greens in a situation like this, or is that fine?
Fine.
Okay, thank you.
The only time I start thinking about the dark leafy green vegetables or some of your anticoagulants. Coumadin comes to mind as a contraindicator. And then there are some other drug like incompatibilities or people that hold on to potassium. You wouldn't want them to engage in, not potassium, I should say. People who are on certain types of drugs, you wouldn't want them to engage in eating more vitamin K. Yeah, but we'll come to that. It'll become clear when we come to those issues because those issues will come up throughout the lectures.
Thank you.
Mm-hmm. Yes, alcohol. Let me see. Alcohol dehydrates you, though. A drink a day, probably not. You'd have to drink quite a bit of alcohol to become more dehydrated. Yeah, and it would probably depend on which alcoholic beverage you're drinking. Okay, so let me stop with these and get back to our slides. Okay, so I can see John, Lewis, Drew. You see lower respiratory issues? And then give me a thumbs up if it advances to the next slide. Good, thank you. Okay, so talking about acute bronchitis. Some of you have probably experienced this. It's just a really quick onset, not necessarily a disease per se. Inflammation of the bronchi. Some triggers could be dust, air pollution, inhaling certain chemicals. I know somebody I worked with kind of experienced this when they were exposed to pine sol cleaning agent. Smoke can do this to you. Asthma can cause it. But typically it's an acute respiratory distress or feeling of shortness of breath. And typically managed could be like albuterol inhaler, limiting their exposure to what they know would trigger the problem. But pretty much benign. You don't typically see somebody coming in with acute bronchitis into the ER necessarily all that often or being admitted. It's kind of self-limiting and tends to go away. People often experience this when they have other viruses, maybe the flu, the influenza. Some people are experiencing this with COVID as well, feeling like they're short of breath. And of course, certain, I would say advanced evaluation would be necessary, especially in this day and age. Everybody should be treated with respiratory symptoms as though maybe they've been exposed and contracted COVID. So it's not necessarily something to just discount and blow off and say, okay, drink some fluid, go home and rest type thing without testing and making sure it's not something a little bit more serious. Pneumonia, you will see people being admitted with pneumonia. Typically, it is a complication of the influenza virus. Certainly can cause death in people, and I would probably think about my geriatric population as being most susceptible to not only contracting pneumonia or coming down with pneumonia, but also dying from it as well. Immunocompromised patients are certainly susceptible. People who have decreased level of consciousness, if you think about those who've had a stroke or some kind of maybe traumatic brain injury, they can't necessarily take those deep breaths and cough and try to eliminate the risk of pneumonia like the rest of us can do. So they certainly would be predisposed. And then being intubated. People who are on mechanical ventilation, you'll find these individuals in the intensive care units. And there's a special hospital-acquired type of pneumonia that coincides with intubation, and that's called ventilator-associated pneumonia. And we'll talk more about that in XDA 3 when we talk about mechanical ventilation. We know how we acquire it. We can aspirate our own GI, gastric reflux, basically, called aspiration pneumonia. You can, choke on something you're eating that you can aspirate that way. We can just be walking around and get exposed through the environment, interacting with people, being on mass films, and so forth. You see the multiple different types listed here. Again, hospital acquired is just the ventilator associated when somebody's intubated on mechanical ventilation. Necrotizing is very rare. I really probably wouldn't, pay too much attention to it. Aspiration, I see this a lot in like stroke patients. I had a stepfather who actually had like later stages of dementia, and he aspirated on some soup and 3 days later died of sepsis, basically. So that's a possibility. Opportunistic, think back to our HIV vector. Think about, PCP as a type of pneumonia for AIDS patients. Most commonly, you're probably going to be encountering the community acquired. What does it look like? Well, and it is an infectious process. You're probably going to see some systemic type of reaction, fever, chills, fatigue, shortness of breath, or difficulty doing activities without becoming short of breath, an increased respiratory rate. Typically, they're going to have a non-productive cough, but especially if it's consolidated and it's not mobilized, the secretions is what I'm referring to. But if they can, keep those secretions mobilized and expectorate and get rid of them, that's going to be very helpful. They may complain of pleuritic chest pain. Now, chest pain, when somebody says, I'm having chest pain, you really have to hone in on your assessment skills to find out what type of pain that really is, because my first thought is cardiac, and that's the more serious type of chest pain. However, chest pain could be GI reflux. It could be related to the lungs. And so if it's pain that is getting worse on deep inhalation and then lessens on exhalation, that's a pleuritic type of pain and not associated with cardiac. Confused and stuporous. So if you think about hypoxemia with pneumonia, that's probably the link that you can draw as to this symptom of being confused. If you're not getting enough oxygen to the brain, that's probably going to cause some type of cognition changes. I typically see this in older individuals, less likely in the younger population that has pneumonia. Okay? Older individuals tend to get confused more quickly. Adventitious lung sounds. You may or may not hear this in pneumonia. If you have a consolidated section in your lungs that's just this mass of secretions that's not mobilized and not moving, probably what you're going to hear is either absent or very decreased breath sounds in that area. If they do have secretions that are more mobile, then you're going to hear things like rhonchi. Okay? Probably not so much crackles, because crackles is associated with fluid that's more thin, and pneumonia has more thick secretions associated with it. And then some of these non-specific symptoms, fatigue, myalgias, aches and pains, headache, sweaty, not feeling hungry. We can't really pinpoint anything from those type of symptoms specifically to pneumonia because they're just so vague and generalized. How do we diagnose? Ideally, getting a sputum sample, and that sometimes is difficult, especially with consolidated type of secretion. If we can obtain that sputum sample, they can send it, they can do a culture and sensitivity on it, they can do a gram stain. We can see infiltrates or consolidations if they are present through a chest x-ray. And that's what the circle is indicating on that x-ray. Pulse oximetry, that's going to let you know how hypoxemic your patient is. Right? Arterial blood gases, another good tool that we can use to look at the actual concentration of oxygen in the blood versus what is the carbon dioxide level and what is the bicarbonate level. That gives us a really good idea of acid-base balance. Doing a complete blood count. Typically what we're looking for are elevations or changes in their white blood cell count. Doing a differential on that and looking and seeing exactly what cells of the white blood cell count have changed or become abnormal. More aggressive diagnostics would be doing a bronchoscopy where they're sending a tube down into the lungs. Oftentimes they're able to get secretions that they can extract and run for as a sample CNS or a gram stain through a bronchoscopy. Or thoracentesis, where they're sticking a needle into the lung to extract fluid for sampling. But those aren't necessarily the first tool that we'll use to diagnose pneumonia because they're a bit more invasive. How do we treat it? Of course, we know about antibiotics. That's going to be up to your physicians. And if we do have that culture and sensitivity, they can choose the correct antibiotic or the one that the microorganism is going to be most sensitive to. Oxygen. We'll talk about ways to deliver oxygen later, but certainly you probably have some kind of order that says titrate oxygen from, let's say a nasal cannula from 2 to 6 liters based on the oxygen saturation. You're monitoring the SpO2, which is a peripheral oxygenation saturation, and you're probably being asked to titrate to keep levels above, either at or above 94%. You might see some say 95%. Now, let me give you an association to what that means. So that gives us an idea of the saturation in our blood. But to actually know for sure what the blood concentration of oxygen is, you'd need an arterial blood gas. Okay? And that's blood from literally an artery. Not easy to get. So SpO2, we know that 80 to 100 for an oxygen concentration is normal. Okay? So anything less than 80 technically is something called hypoxemia, which means there's less oxygen concentration in the blood, right? We draw our critical line in the sand at a number of 60 or less. Okay? That doesn't mean that patients get to 60 or 55 on their oxygen concentration before they have symptoms. They could have symptoms, even have a ABG that's normal and still have symptoms of shortness of breath, because what's happening is our respiratory rate is increasing to try to compensate for a change that is occurring. So if somebody is adequately compensating, they still may say they're short of breath and have all normal numbers because they're actually compensating for the problem. But that doesn't mean that they're going to continue to be able to compensate. At some point, if they're not treated, they will decompensate and start to deteriorate. And we don't want to let them get there. Right? So when they tell you 94 to 95%, they're basically drawing the line in the sand at the lower level of normal. So if I drew an ABG and their saturation by SpO2 is 95%, that ABG oxygen level is probably going to be very close to 80. Okay, so you're really at 95% or higher, trying to keep them within the 80 to 100 range for oxygen levels. When you get down to 90% and less, now you're at that critical mark of 60 for an oxygen level on arterial blood. Okay? So I just kind of want you to wrap your head around that, because that gives you a really good idea of why you're treating or doing whatever intervention you're doing to try to keep that saturation at 94, 95% and above versus letting them get down to 90%, 89% and so forth. Now we will have patients that, like COPD coming up, that will normally live closer to 90%, and that becomes their normal. And that's a normal for them that we have to accept. Okay, so we're going to find the people that are the outliers. But generally, without any underlying pulmonary history, you want to keep them as close to normal as possible. Okay, So what I want to do is get back on track. It's 1:50, which is our normal break time. So let's go ahead and take our 10-minute break and we'll resume at 2 o'clock.